Hey, good morning, everybody. This is James Case, and welcome to part two of the HFMA, the Maryland chapter of HFMA's HSCRC workshop. This is a continuation of last month's presentation. Like we said in January, we wanted to chunk this into a little bit of two more digestible session. So today is the second part of that session, and we have three fantastic speakers on three highly relevant and important topics for you all to be informed about and ask questions and just enjoy in your day to day. The presentations today are going to start out with an overview from Brett McCone of the Maryland Hospital Association's viewpoint of the state of the model. We'll transition to William Henderson, who will be speaking about the population health infrastructure reports that are due in a couple weeks. And then lastly, we'll have Allan Pack speaking about the full rate application methodology. So we're real excited to have you all today. Just a couple reminders. These will be about 20-minute presentations. We'll take a little bit of a break between each of them to get the slides set up. If you have questions throughout the presentation, feel free to insert them in the Q&A box in the Zoom, and we'll try to get them answered during the meeting. And if we don't get to it, then we'll definitely put together responses from the speakers and get those out to you afterwards. The slides are available, so if you don't have them, they'll be resent out for your consumption after today's presentation. And then lastly, we want your feedback. So if this format works, we would certainly be preferred to be in person in Martins West, but the chapter is hoping that this fulfill some of your educational needs, particularly as it relates to the HSCRC and technical knowledge around it. So without further ado, we'll get into our first presentation for the day. The speaker needs no introduction. Brett does a fantastic job every year at the HSCRC workshop of providing strategy and technical overviews of what's going on in the model, and we're pleased to have Brett join us today and provide that point of view from the Maryland Hospital Association. So Brett, please take it away.
Great, James. Thank you very much. Audio okay?
Yes, it is.
Okay, great. And then real quick, I just saw a question about the slides. Cheryl, do you want to answer that?
Yes, the HSCRC workshop part 1 is available on the Maryland HFMA website. It was recorded.
Great. Thank you, Sarah. Cheryl, thank you, James, for that introduction. Appreciate everybody being here today. Good morning. And the first thing I always do with the HSCRC presentation, having been blessed enough to do this a number of years in a row, is I do want to thank our colleagues from HSCRC. You're going to hear from William and you're going to hear from Allan. I've had the privilege and the pleasure of working closely with them since they joined the commission, and that has certainly been my privilege to do so. There are a number of HSCRC staff that are on the presentation as well as attendees listening. So thank you to all of you for what you do. We always have to stop and take a breath here in Maryland, particularly with the pandemic, and really realize how lucky we are to have this system where we do have the ability to talk and have conversations with the regulators. And so we really appreciate that. So on behalf of all the hospitals and behalf of all HFMA members, thank you very much for what you do at the commission. So with that, let's dive in. And I'm going to share my screen here if I can get there. Okay, if everybody can see that, let me go to, I'll see if I can get to slideshow mode.
That's good, Brett.
Does that look good? Okay, great. So again, good morning, everyone. Things we're going to cover today. We're going to cover a little bit of the HSCRC priorities. Obviously, it's the HSCRC workshop. And again, with 20 minutes, want to give folks a brief overview. I know William is going to dive into the care transformation, population health investment, so I'm not going to spend a lot of time on that. Allan will talk about the full rate setting methodology, but I'll give a general overview of sort of our state of the state view. And then I will spend at least a minute or two at the end on legislative priorities about what's going on in the Maryland General Assembly and what MHA is working on. So the first thing on the total cost of care model, if you look at this is our model timeline with CMS. So, you know, this isn't a surprise. Our model runs through 2028. This is the longer time frame. The interesting point here is that by 2023, most of what folks think of is that by 2023, we have to achieve the $300 million of annual savings target. And then beyond that, we have to reach agreement with CMS as to what those targets would be going forward. So when we think about sort of breakpoints in here, this 2022-2023 timeframe is very important. We also have the opportunity then to propose a permanent model approach. Now we can debate what is permanent, but the idea is that we can propose to CMS a permanent model. They would likely implement that through regulation and through rulemaking. And then, you know, with a much longer run out beyond 2028, depending on what the conditions of that model are. So as we think about the real big picture here in Maryland, we are unique and we have our payment system because Medicare participates in our payment system. Those of us who have been around a long time know that New Jersey, New York, others had similar payment systems that went by the wayside for a variety of reasons. But this is our contractual agreement with CMS, and this is what we're really thinking about and focused on going forward. And of course, you know, there's the financial targets, but we really are thinking about the bottom, about measures for quality population health. And the last bucket, I think, is really important around care transformation and what that truly means. So if we think about this, just the savings targets, if we look at the all-payer model that ran through 2018, from the total cost of care savings, by the end of 2018, we had 273 million of savings. At the end of 2019, we have about 340 million of savings. CMS is still reconciling a question at the end of that year. When we set the targets, though, the savings targets, we were here in 2017, you know, working to reach agreement with CMS, and we set the target at 120 million. So interestingly enough, we had significant savings in 2018 and 2019. So if you look at the ramp up of where we need to be in 2023, we've exceeded that number. We certainly, of course, though, have to maintain our strong performance. And then more importantly than just the savings target, because this is, of course, you know, the difference in growth rates between Maryland and the nation. We still receive on an absolute basis higher Medicare payments here in Maryland than we do outside, than we would if we were under IPPS and OPPS. So one of the key questions, even though we are tracking, you know, with reducing savings relative to the growth rate, CMS will ask the question, okay, well, we are spending, you know, this additional amount above IPPS and OPPS in Maryland. What are we getting in return? And again, this is a demonstration model. So what are you demonstrating differently in quality care transformation and population health improvement? So again, this is just the mechanics of the savings target. 2020, of course, just like everything else, is somewhat up in the air because of the pandemic. Happy to talk about that at the end and what that means, but that's, you know, these are the basic numbers. So if we think about the future of the model, you know, the areas we're focusing on, one is, you know, we have to transform care. And this is the question that CMS is asking Maryland to say, what are we really doing differently than the nation? And they really want to know how we are reducing hospital utilization, And what does that transformation model look like that reduces per capita spending? So as we think about going into the next phase of the model, and again, we've been working closely with the commission on this, we really have to think about, what does transforming care mean? A couple key things, if we think about, you can think, very basically, which I think are important things, like, transitions of care or enhanced care management. If we think all the way back to 2013, we probably have much more robust case management functions in the hospital, and utilization management functions as to whether patients should be admitted or we can manage them in the community. We have the incentive under GBR, if we can, to keep people out of the hospital, and that was a game changer. So if we think about those things, something as simple as that really provides, the GBR provides the incentive, and we really have done some basic lifting at that point. If we go further down the path, we've done investments in partnerships with post-acute providers and other partners, where, for example, post-acute providers, in some cases, we have adopted advanced telehealth pre-pandemic to anchor that in long-term care institutions to prevent admissions and readmissions from those long-term care facilities coming to hospitals. Perfect incentive under the model. And again, areas that we've got to demonstrate that we're working together. Then the question becomes, how much is this different than the nation? We think about going even further upstream, we really start to get into questions around community health and the investments that hospitals and others are making there to reduce the healthcare spend. So if we think about this at the very basic, at the core of the model, how do we get better value out of our healthcare dollar, one, or two, how do we avoid the dollar of healthcare spend altogether and either replace that with a lesser spend with a smaller dollar, if you will, or again, avoid it altogether. So those are the things that we're thinking about, is that housing partnerships, is that increases in primary care within senior housing areas, mobile integrated health, all kinds of different things. So again, big focus area of the model. If there's one of the three to take away, this is going to be one of the three that we're focused on. Next, of course, we have to establish a reasonable savings target in the future. And I think that's largely going to depend on what the care transformation targets are that we agree as considerations of the future model. In some cases, depending on how far upstream we go, I would argue if you're really trying to attack the social determinants of health, then the savings targets need to be run out on a much longer time frame, because we're going to need that time to invest and really have generational changes to affect social determinants of health to get the changes we need. So of course, we're looking to establish a reasonable savings target, and that will be a long discussion as we work to try and establish that for Maryland. The last piece I think is also important, and if I put a little more of my MHA hospital advocacy hat on, I think the key here is we want to increase, you can use whatever word you want, participation, influence. We like the word accountability among all stakeholders. Because if we think about transforming care, it can't just be hospitals making these investments. Sure, we have retained savings and some other things under GBR to have those investments, but this really needs to be partnerships among state and local governments, other healthcare providers, physicians, and everyone, including health plans, both the commercial health plans, I would say the Medicaid managed care organizations, and really how do we all partner together to row in the same direction if the North Star is to improve the health of the population and reduce the healthcare spend. So again, this is going to be a key focus area as we move forward about how we bring all of these folks together so we agree and continue to try and paddle in the right direction. Some of that we may explore contractually. Some of that may be administration by the state. So those are the big areas we're thinking about for the future of the model. for this particular year coming up, we've got, a few key things. And I'll do this, if I think waiver is very long-term, on the horizon, over the horizon. But I think sort of more immediate term about calendar year 21, a couple major things going on that we are working with commission staff and hospitals to address. One is the new efficiency policy that we have proposed. And I'll break this down. You can use that word sort of globally. A few different things. One, we need to determine a new scaling method. And I know Allan is on the webinar today, and we'll talk about the full rate application. I'm not sure if he's going to talk about the efficiency policy, but again, just proposing changes to the scaling methodology about making it like a continuous scaling for those hospitals that the commission believes are inefficient based on the measurement. So that changes what hospitals have identified and what scaling would be used to adjust hospital rates. The same thing on Wednesday, the commission had a meeting on the revisiting the peer groups. And so again, this is important because many hospitals have argued to the commission recently to say, look, we really need to address the peer groups. And until you address the peer groups, whether it's in full rate applications or just discussions with the commission about rates, we're not really going to make headway because we think that we need to, address the peer groups. So the commission has come out with a straw man proposal to do so. And in fact, the proposal would eliminate the peer groups when we think about hospital comparisons, and then look at more direct adjustments to compare hospitals to one another across the states. So that's just been proposed, but that's going to be a big piece as we think about things going forward. The last piece of this is then the total spend per beneficiary benchmarks. We've talked a lot about this. This has been, at the public meeting, this is 50% of the efficiency policy. And that is looking at total cost of care per Medicare beneficiary and per commercial enrollee. Excuse me. And if we think about this, in our system, you could argue that this is even more important than looking at unit cost efficiency, because the incentives in our system are to reduce total spending per beneficiary. And when we think about that, that's both price and use. Historically, we've always regulated price, and we've had limited controls over use up until we went to the all-payer model in 2013. So this is appropriate then that we would look at total spend per beneficiary. And again, looking at benchmarking comparisons, Maryland versus the nation, sort of like hospital service areas compared to each individual hospital. And then that gets aggregated when we think about, potentially overall targets for the future. So again, big things, big changes there. We're working with hospitals to get input and feedback to the commission on these things. Any one of these three things by itself is an enormous undertaking. But as the hospital field, we look at these things. We do need to lean in and digest some of these things. Second thing, and William's going to talk specifically about this, is about summarizing care transformation and population health investments. This is important because if we think about our model, right, our model is designed to, the most expensive healthcare dollar is the acute care spend. So what are we doing to transform care, to invest in population health? And you can define these terms however you want. But again, I use the North Star to say, how are we replacing $1 with a cheaper dollar, or how are we avoiding that dollar altogether? So what are we investing as hospitals and health systems to do so? We have the incentives under the global budgets to do so, to keep people out of the hospital and retain that savings. A fair question to be asked is, how we are spending those savings and what we're doing, because we can argue that while we're saving dollars on the hospital side, I have routinely pointed out, we're making lots of investments outside of the hospital to do so. There may be a million value judgments on those investments depending on the community, but in some cases it is investing in primary care. In some cases it might be investing in specialty care. In some cases it might be access to low-cost imaging. In some cases it might be partnerships on housing. But what are we doing to do that? And then, of course, how does that affect the efficiency when we think about the spend per unit? Because our spend is essentially, going up slowly, but the units are flat or going down across the board. A couple other things. We have identified the wanting to revisit the annual filing cost allocations. If we think about the cornerstone of the system, that rates relate to reasonable costs, this is one that we're HSCRC staff, and I think hospitals, as we think about what's happened to prices over the years, something we need to revisit. The staff were very gracious in pushing this off in the face of the pandemic. I'm not sure we will get to this in calendar year 2021 or at least into the future. But what's important is that we are going to have to revisit this, whether this is indirect allocations or how we capture and define rates. This is an important conversation, albeit a very mechanical one and a very basic one, but one we need to make the trains run on time. And the last piece then, the sort of coupled back up with the efficiency policy, is this idea to adjust volumes to the most recent period as part of the efficiency policy. And this is, as all of you know, we adjust rates to achieve our global budget. Well, out of the gate, we're always thinking that our volumes trail whatever the most recent trend and period is. Right now, we still have those volumes sort of set back on a 2013 base, and it makes it very difficult to manage compliance. So another big piece. So our immediately right now, this is top of mind for everyone, is addressing the CARES Act funding. And this is, there are hundreds of millions of dollars here. Hospitals have received over $1 billion in funding from HHS. Again, HSCRC, big thanks to the commission for being a huge shock absorber for what we had to deal with last year. And in some cases, we certainly are on much more stable footing than the nation, given our ability to adjust prices here in Maryland in calendar year 2020. Now, some of that, of course, we've got to figure out then. It was said from day one that we would leverage federal funding first. So we have to, get through this process. Couple key things, of course, addressing the regulatory guidance. HHS is the grantor. Hospitals are following their guidance in what they have to do to retain the monies. And that is, the frequently asked questions, I think, from HHS are up to 65 pages. And there's lots of detail and audit requirements and all sorts of things. So we're working with that. The big focus right now is what position should the HSCRC take to replace previously given rate support with federal monies. And that's something that, we're working through that discussion with the commission right now. There was a work group meeting in January, an initial presentation at the February meeting. There's some mechanical issues there. And I think I'm fair to say there's also some philosophical policy issues that we need to deal with respect to rate support received. And a lot of that has to do with how HHS distributed the money. So again, looking at, rate year 20 versus 21 versus the CARES Act, I think the immediate step is looking at the compliance measurement periods and what pricing relief was granted, what undercharges are expected. And then, of course, we have to understand the implications for Maryland's model test as we think about our year-over-year guardrails and what that looks like going forward. But again, big focus area. We appreciate the staff extended the deadline for comments on this until March 11th. The original deadline was this past Wednesday. And we as a hospital field, MHA, will have a comment letter. And we're working with our hospitals to get their inputs to shape that. And then finally, just real quick from an MHA perspective, just jumping over to the legislature quickly, you can look at the 2021 legislative priorities, things that we support and things that are concerns. One, we had liability protection for Maryland's hospitals. This is of the utmost importance about protection for liability and acting in good faith during the pandemic. And this is something that, liability is a tough climate in Maryland. If there are trial lawyers on the phone or on the presentation, appreciate they have an opposing position to this. But we really believe that, we've all acted in good faith here, and there needs to be additional protections. Telehealth. MHA introduced the Preserve Telehealth Access Act of 2021, and essentially to maintain the expansions that were done during the pandemic. If one thing that we want to think about, we talked about replacing $1 with another dollar, is expansion of telehealth, a major expansion of telehealth that we've seen during the pandemic, with the idea of keeping people out of the hospital long term. We know we retain some of those savings, but this is important, I think, a really important issue to transform the landscape here. Then next, the House and Senate health equity packages. We are firm supporters of that and the need to address equity. A couple key concerns here. The employer challenge is the Essential Workers Protection Act would require increases in pay for those frontline workers. Again, we very much support all of the great staff at hospitals and health systems. This is a challenge because of the magnitude of what the impact of that may do. If we're talking about mandatory pay for certain things. If I look at I'll jump down to the state budget. Just looking at provider rate cuts to physician rate cuts and other rate cuts from Medicaid make that challenging, and also proposing to increase the Medicaid deficit assessment by another $35 million this year. So those are concerns. The last one, and there was a hearing yesterday about hospital billing and collections and medical debt. This is a distinct balance. We, of course, as hospitals, support and offer financial assistance and charity care to any patient that can't pay here in Maryland. What we've seen, of course, is an explosion in high deductible and high cost sharing health plans over the last 3 to 8 years that have largely driven higher out-of-pocket costs to folks. And they may not recognize it till they need services. And at that point in time, we are in the unfortunate position of collecting on the contractual relationship among the hospital and the patient and the health plan. And so there's some real challenges there. We certainly want to make this much more patient friendly, but there are some challenges there because we do have to balance making good faith efforts to collect on hospital bills in order to keep prices low in our system. And in order to share that burden across everyone. So with that, I'm going to stop talking. Appreciate everybody joining this morning. You are welcome to put questions in the Q&A box. I'm not sure if we're doing any live questions, Cheryl or James, but I'm happy to answer questions the best I can if you put those in the Q&A box. Or if you're doing live questions, I'm happy to answer any live questions if I can.
Yes, Brett, we're asking people to put them in the Q&A. Thank you.
Okay, so if you have questions, please put them in the Q&A and we'll try and speak to those. Your thoughts, your questions, please.
Give it 1 second here and see if any pop up. We don't have any at this moment in time, but let's give it 1 second, see if folks get a little less shy. Normally I can strong arm everybody into at least asking one question, Brett. All right, it doesn't look like we have any, but if folks do have questions or they don't get it in before Brett leaves here in a second, Brett will we'll accumulate those and consolidate your answers and send them out to the group. But thank you, Brett, for speaking today, and thank you for your continued support of the chapter.
Thanks, everyone. Have a great day.
All right, we are going to move into. I said we would take a break, but we're a little bit behind schedule. I like to stay on time, so we are actually going to move right into our next presentation and speaker today. So let's see if we can bring William Henderson to the floor. Hey, Mr. Henderson. And Kalita will pull up your slides, I believe. Let's see if we can get that going. While Kalita's doing that, let me just introduce William to folks. I'm sure many of you know William. William's a principal deputy director at the HSCRC. He's the director of the Center for Medical Economics and Data Analytics, focusing on understanding the data, a lot of the data that the HSCRC collects to help manage the model. Prior to joining the commission, William held a variety of finance and analytics positions with the National Managed Care Company, most recently Senior Vice President of Analytics. And we switched up the topics a little bit today as things have been evolving quickly on the CARES Act side. So we're actually going to speak to the population health infrastructure reports that are due here in a few weeks. So thank you, William, for joining us. And everybody, please welcome William Henderson.
Thank you, James. You hear me okay?
Yes, we can.
All right. Well, good to be talking to folks again, and appreciate Brett's warm words about HSCRC staff, and certainly we appreciate the chance to work with the industry on an ongoing basis. As Brett said, as James said, we did switch the topics up here. Originally, I was going to talk about CARES funding, but that's fairly in flux and just didn't feel like I could present something that would be both accurate and timely. So we're going to deal with another topic that is active right now, which is the population health reporting. So we'll be going through that. If I could go ahead and get the next slide. But in recognition that we were going to talk about CARES funding originally, I did put in one slide on that, or I think Brett has mostly covered what I was going to say already. Then we'll talk a little bit about the population health reporting and why we're pursuing that. Then I'm going to go through the schedules at a pretty high level. As 20 minutes, I can only go so much. And then just outline what we see as the timeline for the population health reporting going forward. So we can get the next slide. On the CARES funding, basically the staff proposal that was presented in the last commission meeting was to treat the CARES funding like any other revenue and count it towards the global budget and true up against the global budget. There are certainly other options out there. The comment letters on this, we did extend the deadline. The date Brett gave is correct. What's on this slide is wrong. It's March 11th, not March 12th. I had to put this in before we finalized the deadline. So March 11th is the right extended deadline for the comment letters. Couple of the items in addition to the fundamental policy question we're looking with that is how do we allocate CARES funds between regulated and unregulated business, an input on how we should calculate the COVID related expenses in considering that policy. At this point, the staff proposal is to focus on net change in expenses. And by that, I mean, we aren't proposing to go out and count every dollar that was spent on COVID related. We're rather looking at overall totals and saying net were the savings from other things that reduced during COVID offset the additional expenses of COVID. And if that's the net position, then we would view that as a zero add. If the expense adds exceed the savings, then that is an add for COVID. The other piece of COVID policy that is out there is a COVID surge policy was passed. It was actually originally passed in like April of last year, was reinstituted in December with an effective date of November 1st. And so we are putting together policies. We're putting together an analysis of what hospitals are entitled to under that COVID surge policy. I think at this point, we're probably going to hold those analyses until we've run the full period, because it does look at the entire period under that policy. I think potentially we'll be looking at proposing the commission ends the COVID surge policy at the end of February in the March meeting, because the volumes are down pretty much where they were when it was reinstituted on November 1st. And assuming that once the policy's ended, we'll then pull together an estimate for the entire period and share that with hospitals. But if folks have questions about how we're going to calculate that, please feel free to reach out to myself. That's all I'm going to say about CARES. So now moving over to population health reporting, if we could go ahead and move on to the next slide. And Brett actually did a really nice introduction of the purposes behind this. So some of what I'm going to say here is very similar to what he just said. I think of this as having two main focuses. The deal in the model is that hospitals will have savings under the global budget from reducing acute utilization, and that they will reinvest those savings in their communities in the goal of promoting health and further reducing acute utilization. But we have two challenges in that. The first challenge is that we're using a set of cost reports that were built to monitor cost for an acute hospital, and therefore don't do a good job of understanding money that is spent in ways that are outside that acute hospital and focused on upstream avoidance of care. And second, we have a cost report that is focused on a hospital entity, and what we increasingly have in the state is a set of systems, and quite often the spending they're doing on managing population health and care transformation is occurring outside the hospital entity. And those two things have really led to this new population health reporting, where we're trying to better capture spending that is either buried in a related or generic category in the existing cost reports, or is occurring at the system level, so we can understand what is being spent with the two goals on this slide identified, right? One is we just want to understand what's out there, right? We've generated a significant utilization savings. Those savings have been reinvested, and we want to understand those reinvestments, where they are, what's the magnitude. And the second is that we want to credit those investments in specific policies, because particularly in an efficiency policy where care delivered in the acute setting is the denominator, right? We're calculating cost per unit of care delivered. A hospital that has successfully reduced the amount of units of care but reinvested that in money that is spent in less traditional ways actually looks inefficient. So we want to be able to understand if a hospital is effectively investing in care outside the hospital or in avoiding care outside the hospital, that we aren't just treating them as an inefficiently run hospital. So that's sort of the practical way, and we'll be continuing to work with Allan and his team on how we integrate the information we gather into those policies. But I think the nearer term goal is kind of the first bullet on this slide, which is just let's understand what's out there, how much it is, and think about how to quantify it, because it's not easy, right? The definitions are gray and the lines are fuzzy. So I think we really view this initial pass that we're covering today, and which is in the report that's due March 31st, as an experiment in understanding, what can we gather and how can we strike a balance between gathering useful information, gathering information that's sort of accurate and not is just sort of made up to fit the reporting, and that also doesn't create a total nightmare of reporting headaches for hospitals. So generally the things we want to make sure we include are those executive and oversight resources. So a lot of our hospitals, I think, have invested in population health departments. We want to make sure we understand that and credit that appropriately, and it just doesn't show up as generic management spending. Because one of the challenges we have right now, and one of the reasons that led to this, is that when I look at the growth by cost center in spending in the annual filing, one of the fastest growing cost centers is the management cost center. And that isn't a good story when you just look at it at that level. But I think when you consider that a lot of these population health investment type resources are probably getting swept into that bucket, you're going to get a somewhat different story, and we want to understand that. Second, and probably more importantly, right, is there are a bunch of resources that are committed to enhancing care beyond what is billed in traditional reimbursement. And as Brett kept saying, replacing $1 with a cheaper dollar. And we want to understand those resources. The existing annual filing doesn't really have good categorization for those resources. So my suspicion is hospitals will put them in a variety of places. And in many cases, I think they're actually outside the hospital entity. And that's why this reporting does include provision for system level data. Probably one of the fuzziest and grayest and most controversial lines that we're looking at in terms of thinking about population health and care transformation spending is how to treat the cost of physician practices. I will tell you, when staff started down this path, our easy answer was, we're just not going to count any physician costs, practicing physician costs as population health, because there's reimbursement for physician services and it's not population health if you are simply providing a bunch of physician services. I think the industry made a counter argument that I think has a lot of truth to it, and we wanted to recognize, which is that in many cases, when I'm investing in a physician practice of a certain kind, that is a population health investment, and I may be subsidizing that practice because I believe I'm going to have better outcomes with adequate supply of physicians, and therefore it makes sense for me to put money into physician practices. However, I think that said, we still, I don't think, believe that every dollar of physician spending is really a population health or a care transformation spending. We're just not really sure where to draw that line. So the compromise we've done for right now is we have asked hospitals to include in their population health reports all of their physician spending and then break it out into some categories. So I've had that question a few times about what physician should be in and what physician should be out. I think the answer is they should all be in, because really we don't know right now how to draw a line. I think excluding all physicians was probably not the right position. So our fallback was, let's include all physicians and then let's try to figure out appropriate ways to slice them up in terms of what we will count in this population health and what we won't. So in future reports, we'll have a way to subdivide that. So what I'm going to spend the rest of the time today doing is going over the schedule in a little bit more detail. So we could go ahead and go to the next slide. This slide is a slide we developed with MHA when we started the work group that kind of went through some guiding principles. I hope we've stuck to these. I don't know that we've perfectly stuck to all of them, but this is really sort of what we looked at and we tried to think about. The one I want to focus on here a little bit is auditable. We did choose to build this into the annual filing because we want to be able to leverage the audit aspects of the annual filing. There is a fair amount of crossover with the community benefit report. And so that's one thing we'll be working on, figuring out how to rationalize those two things. But we viewed this as part of the annual filing because of that auditable aspect. So we can go ahead and go to the next slide. All right, so this is a view of the schedule. There's really two schedules, Schedule 1 and Schedule 2 in the reporting. There's also detailed instructions, or at least semi-detailed instructions. So I do encourage people to read through those. I have not tried to recap everything that's in the instructions today. So Schedule 1 looks conceptually like this. It has 5 sections: direct expenses, non-physician, direct expenses, physician, indirect, non-physician, indirect physician, and then reimbursement. And it, broadly speaking, has, it really has many columns depending on how many hospitals are in the system, but it is a system level report. So each acute hospital within the system would be its own set of columns. And then there's a health system non-hospital set of columns so that systems can submit spending that they believe fits these categories, but occurs at the system level. I will go through each of these 5 buckets in a little bit more detail in the following slides and what we're trying to capture in each one. Schedule 2 basically looks at, really it's the top, it's rows 1 and 2, and it asks you to take that same total that you have in blocks 1 and 2 for the regulated hospitals and split it by the annual filing cost center category that it's recorded in. So you'll notice the health system non-hospital column is not green there, and that's because There is no annual filing there, so you're not going to be able to tie that out. So this only applies to the acute hospitals where you have an annual filing. But basically what we're saying is if you've figured out that your direct expenses non-physician spending is $1 million, tell us that I recorded 500,000 of that in the management cost center, 250,000 in nursing administration, and $150,000 in the medical care review bucket. And the reason we're interested in that is because of that, one of those goals I said of understanding what's happening in the annual filings, right? One of the things we want to be able to do is understand how the management cost center growth over time relates to investments in population health. You did have a discussion with Brett and Laura Russell the other day about the challenges maybe of Schedule 2. You know, I hope it will be doable because I'm assuming these things ultimately all tie back to a GL that then maps up to these categories. But I think in Schedule 2, even if you need to approximate it, I think that's fine. I think we would like to see folks telling us how the expenses they've identified are spread across their annual filing. Box 4 is highlighted in green. There actually isn't in Schedule 2, box 4 does not appear in Schedule 2. The reason I highlighted box 4 in green is that the way the instructions read, the sum of box 2 and box 4 should equal your physician reporting in your annual filing in the physician unregulated cost centers. So 2 plus 4 will equal that. It doesn't really require reconciliation, but that's sort of part of the way those categories are defined. We can go to the next slide. So box 1 is direct expenses for non-physician. The blue box on the right here is basically copied from the instruction and tells you how we define those things. But I'd like to emphasize that first sub-bullet point in the left that says defer to hospital judgment, particularly in the first year. You know, I think we have said this is very much an experiment and a prototype. So if you feel strongly that you have something that should be population health that doesn't meet the 4 criteria to the right, you know, I don't mind if you put it on its separate line. We included plenty of sections for discussion, you know, put something in the discussion. I would prefer that you stick to those 4 bullets because we really want to try and get everybody consistent. But I do want to acknowledge that we wanted to give hospitals a chance to weigh in. So like I said, if you have something that you think clearly doesn't meet those 4 criteria, but we really ought to count for some reason, you know, make it there's plenty of lines in section 1, right? It's broken into, you know, how many lines you want to break it into, just make it its own line and put a footnote and say, we're including this because of X, Y, and Z. One of the criteria that's on the right there is that you receive no or nominal reimbursement through underinsurance or through grants. So that's requirement number 3 on the right. I just want to emphasize that one. The reason that's important is because the point of this report, right, is to understand how hospitals are taking their GBR and reinvesting it in population health. If you are getting reimbursed for that investment through another source, then we wouldn't view that as an investment in your GBR because you're not investing in the GBR if somebody else is paying you to do that activity. So if you have a grant covering that activity, you are not investing your GBR if insurance pays for it. Where I think that gets gray is clearly partial reimbursement, right? I'm getting reimbursed for 30% of this spending, can I include it? And the instructions go through our thinking on that, and we'll certainly be looking to refine that. We suggested a 60% rule. Basically, if it's less than 60% funded by other sources, then you could count it, and if it's more, you couldn't. But I know that's certainly an area of grayness. You know, I think the other thing that's gray here is where you get into costs that are very distributed, and we'll have to work through how that is handled. So that's the direct expenses, but generally the goal here, right, is what are we spending that directly goes to population health? One thing I think another aspect that's in the instructions that I'll maybe hit here is management costs. What we said in the instructions is if you have management that is 100% or 90% focused on population health, your VP of population health does nothing but work on population health, you should include that as a direct expense. What you shouldn't include as a direct expense is if, you know, CFO is spending 10% of their time on population health and a chief medical officer is spending 15%, that we would view as indirect. management would only be included in direct to the extent that they are management folks who are dedicated to population health. We go to the next slide. So this goes through some of the examples of programs we thought might fit in there. I'm not going to go through all those. I'm sure there's other programs, but it gives you an idea of the things that fit in there. What you actually include will depend a little bit on what you're doing. But these are some things that we could think, and this is a pretty comprehensive list right now. So I guess kind of what we're saying is conceivably any number of things could fit in here. We can go ahead and go to the next slide. All right, the second category is direct expenses physician. So again, I've copied from the instructions the categories here. The direct expense physician bucket is only supposed to capture the actual cost of the physician. So not the support staff, the medical assistants, etc., but costs of physicians. And this is also supposed to capture the physicians practicing as physicians. So if you have an individual who is 50% a practicing doctor seeing patients and 50% of the time supports your population health initiatives and attends HSCRC meetings and establishes strategy, then the only piece that would go in here would be the 50% of their time that they are seeing patients. The other 50%, if it's dedicated to population health, would be in category 1. If it's more broad, it would be in the indirect bucket. Again, we're including all physicians in here because we didn't want to try and draw a line of what are population health related physician costs and what are not. So we asked people to include all physicians. So this should be a pretty clearly for the regulated entity, right? These are going to be the physician costs that you already report on your unregulated schedules. I think that's probably the key messaging here. It should not include intern and residents because those are provided for in separate pieces of the model. So we don't view resident, intern, and teaching costs as part of this. We go to the next. So then after the two direct expenses, there are indirect expense buckets for non-physician and physician. They're actually a little bit different. Non-physician is going to be where you allocate all of the non-dedicated management and all the other stuff that supports those people in some way that hopefully is consistent with your existing allocation methods. So within the cost report, right, we allocate technology across all the other cost centers. So, I think you would use that same methodology based on your direct costs to allocate technology here. So we're trying to get a sense of how much load we should put on this. Because this is pretty subjective, that's where we've asked people to stick to their existing allocation methods. I think ultimately we may do away with indirect and just announce that we'll calculate the direct and then multiply it by 1.x. And that will be our total so that we don't get into everybody's different allocation approaches and so on. This is also, you should allocate the physician, if you have physician management executive people, they should, in this case, be allocating in the non-physician bucket, because what we've asked for in the indirect physician is all those physician support costs, medical assistants, and so on, the costs of running physician offices. And our thinking is that the direct plus the indirect physician should equal your existing unregulated costs. And we did that because we did want to kind of reconcile to the physician costs in the unregulated schedule for the regulated entities. You have that column for the system. That one's not going to reconcile to anything, so you'll have to use your judgment exactly where it goes there. We can go to the next slide. So the last section is reimbursement. This is a little bit different for the physicians and the non-physicians. For physicians, it's basically going to be all the revenue because we're reporting all the costs. We're not making a judgment based on losses and so on or splitting here. So you should be reporting all the revenue. In the case of the regulated entities, it should tie to your filing, right? You report some revenue number. If you report them gross, I think some hospitals don't report them gross, in which case there may not be a revenue here, but basically for the regulated entities, this should be the revenue you report on your filing. Again, for your unregulated piece, you're going to have to figure that out. But on the non-physician side, right, because those are defined to be things that don't have reimbursement, we are expecting not to see a ton of reimbursement here. That said, as I acknowledged earlier, we recognize there's things that are partially reimbursed, and that's where we suggested the 60% test. That if it's less than 60% reimbursed, you could report the costs, gross, and then you report the reimbursement in this section. So ultimately we get to the net cost of that service. So this would be where you would report if you've got a function that receives grant funding that covers 20%, then you would report the 20% of the grant here, or maybe you're way over invested. We know that there are population health clinics, right, where you do bill for them, but you provide a ton of services that are way more expensive out of the GBR that you don't bill for. And so in that case, you might report the entire cost of the clinic and then report the piece that you do bill for in the reimbursement, depending on the coverage there. I think the other alternative we suggested there is if you've got a clinic that is mostly reimbursed, but you provide extra social work services, that's an add-on service that isn't reimbursed, you could just report the cost of those social work services and then assume everything else is reimbursed. So certainly looking for hospitals to use their judgment there. The idea ultimately is we do want to get net cost of your investments and not gross cost, because we want to recognize that there are other sources for these investments. So timeline for this, the first report was extended to March 31st. Like I've noted, this is a prototype, but it's experimental. We're definitely interested. We provided plenty of sections for comments. Feel free to add comments and discuss. We will be doing some work groups in the probably May, June timeline to discuss that further. I've got that down below. Just want to note, we will not be using anything in the report you submit on March 31st in any methodologies. So we'll use that to build the report for next year, and that's what we'll roll into methodologies, but we will not be using that data in methodologies. We will be sharing high-level data, right? I want to make it clear, I'm not saying that what you report will never be looked at by anybody. I think we'll share publicly and with the commission at a high level. Here's sort of what was reported, here's the issues and so on as informational, because I think it's important we begin to share that information, but we'll caveat that. I don't think we'll call out individual hospitals or systems in that. We'll sort of say, here's what we see statewide, here's where we see a lot of variation, here's some of the issues that have been raised. Given that, the timeline, like I said, we don't have a ton of time given the extended deadline of March 31st to compile the data, revise the reports, and get it out to folks so that they're aware of it as they begin to close FY22. We will be looking, I think it'll probably take us a month or so to get through the data. So then we'll be looking probably at a couple of work groups in May and June to share what we found and propose revisions and revised instructions and so on. We will then look to send out the revised instructions when we send out the FY21 annual filing template or shortly thereafter, so that folks are aware of that as they go through their year-end close processes. The report right now will be due 30 days after the annual filing, which is 11/30. Hoping to avoid extending that again, but clearly things are in flux. And then we'll be looking to compile and understand the results from that submission date through the spring of next year, and looking to add to methodologies that are then implemented in rate year 23. So I think that's the end of my presentation. So sounds like we have a window for questions.
Yeah, there is one question here, William. The question states, if a grant requires in-kind cost, are those considered non-reimbursed or reimbursed costs for non-physician allowable costs?
I think I have to think about that one. I don't think I want to try and answer that on the fly. So I'll get back to, I guess that's Camille. So I can get back to Camille.
Okay, very good. Any other questions from the audience? If you want to post something in the chat or the Q&A box, I can ask them on your behalf. You'll give it a second here. All right, William. Well, thank you so much for your time. We really appreciate it.
Okay, thanks.
All right, and William got us back on time, which is great. So we'll roll into our last speaker of the day. If we could bring up Allan. There he is. Hey, Allan. So Allan, thanks for joining us. Just to introduce many of you and re-welcome Allan to the HSCRC workshop stage, virtual stage. Allan is a principal deputy director at the HSCRC over the Center for Population-Based Methodologies. He oversees a variety of different methodologies, none maybe more complex and interesting than the full rate application and efficiency methodology. So please virtually welcome Allan to the stage. And Allan, why don't you go ahead and take her away?
Great.
I think we're going to pull up your slides here in a second.
Okay.
And we can hear you.
Great.
There we go.
So you can see my slides. Great. All right. So I just wanted to start by thanking HFMA for giving me the opportunity to speak again today. It's a wonderful conference that we have every year on this. I think now more than ever, it's important to, that we stay connected and I can continue to advance our very unique health model that I believe it was once again proven its value during the COVID public health emergency. So thank you to HFMA. Today, I'll be going over the full rate application methodology that was approved, or I should say policy, that was approved by our commissioners at the January commission meeting. In terms of agenda, first, I'll just touch on the general policy overview and then discuss the historical use of full rate applications. Following that, I'll touch on the most difficult aspect of this methodology, which is how to incorporate total cost of care performance into full rate reviews. And finally, I will go over our proposed process for handling full rate reviews in our model, which requires adherence to various total cost of care savings tests. This is our policy overview slide, which many of you probably have seen now in our various policy papers, as it's a required overview from our chairman and executive director that essentially summarizes the impact our policies have on various stakeholders. I won't go through all of it, but I will first just touch on the policy objective. Essentially, this is not a policy that staff put forward to further the model per se. It's actually required that we have a review methodology when hospitals exercise their right to file a full rate application. Moreover, it's important to note that in such a methodology, staff must adhere to its statutory mandate to establish rates that are reasonable and reasonably related to costs. Our policy solution then is to use the ICC, our cost per case efficiency analysis based on current services provided at the hospital, and to layer in hospitals bearing on total cost of care for its surrounding region. I won't be going over the intricacies of those individual methodologies, but certainly if anyone has any questions offline, I would be happy to discuss those. So before I go over the meat of the methodology, I think it's important to note that historically the HSCRC has had a full rate application methodology really to adjudicate two things. First is when a hospital actually submitted a full rate application for an increased rate structure, or secondly, when the HSCRC staff identified a hospital with high cost and efficiency in order to reduce the hospital's rate structure, which we refer to as spend downs. Typically, these assessments were based on cost per case efficiency relative to a peer group standard, which is to say, how does a hospital compare to average peer group cost per case plus a 2% productivity adjustment? Because historically, the commission did not want to provide rate enhancements for just being slightly better than average cost per case. I'll also note that this assessment, although a relative comparison to other hospitals' cost per case, has always been attainment only, meaning there have never been additional adjustments for improvement in efficiency, utilization, et cetera. So at the start of the model, there was a moratorium on full rate applications because one, staff needed to update the ICC for things like improving the case mix adjustment or ECMADs, which I'm sure you're all happy I'm not discussing today. And two, staff needed to incorporate total cost of care efficiency assessments to reflect hospitals' broader accountability in the total cost of care model. In effect, staff needed to complement the Commission's existing methodology with total cost of care efficiency assessments, while at the same time adhering to the state statute that requires the Commission to ensure each purchaser of hospital services that total costs of all hospital services offered by or through a facility are reasonable, and that the aggregate rates of the facility are related reasonably to the aggregate costs of the facility. So before I talk about, some of the further meat of the methodology, I think it's also important to note one of the key distinctions in a full rate application versus other efficiency policies. And that's the idea of relative ranking versus an absolute standard. For the integrated efficiency policy and to a lesser extent, the capital policy, staff incorporated relative ranking, which allowed the Commission to more easily integrate total cost of care into cost per case efficiency assessments. In effect, staff use relative ranking of both efficiency tools, which are potentially at odds with one another. I'm not going to lie about that. And we did so as a way to get around them driving to a composite calculation or absolute value. I would also note that in an ideal world, staff would only use total cost of care, but because the GBRs are based off of 2013 hospital budgets and volume, I would add, as Brett mentioned earlier, we have the statutory requirement to make sure that hospital costs are reasonable and charges are reasonably related to those costs. On top of that, I would also note that full rate applications have always been analyses relative to an absolute standard so that the Commission may reset a hospital's rate structure to be in line with its current services. And finally, I would just note that unlike the integrated efficiency policy, which has a cap for how much funding can be provided to a hospital, because the budget for it is, for the integrated efficiency policy, is how much we remove from outliers and how much the commissioners put into the annual set aside in the update factor. The full rate application of policy, in staff's opinion, in my opinion, cannot really be restricted. In other words, whatever a hospital qualifies for in an absolute standard assessment, it has to be provided. And we'll go over the implications of this more in the process section of the slides. So one more important concept before we go through the total cost of care algorithm and how you incorporate total cost of care into full rate is this notion of total cost of care accountability versus responsibility. What I mean by that is that in the total cost of care model, hospitals are indeed held accountable for total cost of care as we manipulate annual inflation in the update factor to hit various total cost of care savings tests. But it's important to note that hospitals are not directly responsible for all total cost of care. In fact, hospital services for all Maryland Medicare fee-for-service beneficiaries represents only 54% of total cost of care spend, and it's even less for commercial, down to 30% of total cost of care spend. Again, in an ideal world, one where we would have GBR based on total cost of care attributed dollars, as opposed to 2013 hospital budgets trended forward, we would be able to assume that a hospital is responsible for 100% of total cost of care. But until we reach such a point, staff believe it is important we reflect hospitals' accountability for total cost of care, but not broad scale responsibility. We believe we accomplish this by using a total cost of care attainment and growth standard and a multi-step algorithm that only rewards or penalizes hospitals when standards have been clearly met. The two additional important points I'd like to point out here is, unlike the integrated efficiency policy, we will express total cost of care in terms of absolute attributed dollars, and we will reflect hospitals' responsibility by weighting these dollars by the statewide spend attributable to hospital services by payer. This is why we multiply each Medicare total cost of care assessment by 54% and each commercial assessment by 30% to get back to that responsibility factor I mentioned. And number two, the output of this total cost of care algorithm is used to modify the ICC. It does not replace the ICC, and nor does it represent a standard share, such as 50% of a hospital's overall efficiency assessment, as is the case in the integrated efficiency policy. So before, again, we look at the actual algorithm itself, I think it's best to understand how the policy works by looking at how total cost of care can actually influence the rate application process. And that's what this table tries to show. Put simply, if someone's total cost of care performance is better than their Medicare benchmark, they get a reward, because obviously that's something that's very difficult to achieve in our all-payer rate setting state. Secondly, if a hospital is better than their Medicare benchmark and the average of top half of commercial performance, which is really indicative of the 75th percentile, they would get an additional reward. If they're worse than the Medicare benchmark, which is true for a lot of our hospitals due to the all-payer rate setting nature, but if they're worse than the Medicare benchmark, but have not grown faster than state total cost of care growth, there's no action whatsoever. The ICC is the final answer. But if they're worse than the Medicare benchmark and worse than average state total cost of care growth, there is a penalty. And then finally, if they're worse than the commercial benchmark, which is quite seldom, there is an additional penalty. And last thing I would just note too is that all rewards are capped so that a hospital does not exceed its Medicare benchmark. So now I'll go over my favorite part of this presentation, the actual algorithm itself. To start, you have a hospital's ICC cost per case result expressed in terms of dollars, because again, we're driving to an absolute dollar value in the full rate application methodology. And that's your dark blue rectangle. Following that, the first question in the algorithm is whether or not a hospital is better than the Medicare benchmark. If it is, the ICC is increased or rather rewarded by taking how much a hospital is under the Medicare benchmark in terms of a percentage and multiplying it by the hospital's attributed Medicare dollars and the share of payments statewide attributable to hospital services. Again, this is the 54% responsibility factor I noted. Next in the algorithm, the question is whether a hospital that is worse than the Medicare benchmark has been growing faster than the statewide average in total cost of care, which is really the metric by which we have held hospitals in accordance with, in order to hit our total cost of care savings tests. If they are not growing faster than the state, again, there's no penalty, but if they are, we do apply a penalty. And it's similar to the calculation I just mentioned for determining the reward, except that the overage is relative to the statewide total cost of care growth. So if we're growing at 7.5%, and a hospital has grown at 8.5%, we don't take them down to their benchmark value. We would just deduct that 1% excess growth. So I'll note in effect, this essentially means that there's a two-step criteria for getting a Medicare total cost of care penalty in the full rate application methodology. Namely, a hospital has to be worse than its benchmark and growing faster than the statewide average. I'd also note that there's no immediate attainment standard by which hospitals are penalized for Medicare total cost of care performance. And then the next phase of the algorithm is really on the commercial side, which is slightly different because we have no total cost of care growth statistics since we just recently started actually developing a way of evaluating total cost of care. And I should stop a second and really thank as loudly as I can my colleague William Henderson, who did a wonderful job in developing the benchmarks for both Medicare and commercial. So the first question then for commercial is whether or not a hospital is worse than the commercial benchmark. If the answer is yes, which actually is the case for one hospital in the state, the full rate application methodology will reduce or penalize a hospital ICC cost per case result using a similar calculation as I already described. I would note though that the weighting is slightly less because the responsibility factor is not 54%, it's actually 30%. After this, the algorithm looks to provide a potential reward to hospitals if they are better than the top half of average performance for commercial total cost of care spend, which again is analogous to the 75th percentile. But in order for us to look at an array of hospitals or an array of geographies we're compared to, as opposed to just one geography, we thought it was better to take the average of the top half. And finally, the algorithm assesses if a hospital receives Medicare and commercial rewards, it assesses whether or not these rewards would take the hospital to a position such that they would exceed their Medicare benchmark. If this happens, we actually cap the rewards so that the hospital's full rate application would not allow them to exceed their Medicare benchmark, which really is in many ways, the ultimate aim of the model. So this slide just walks through the calculations as best I could put into one table. I think I'll just go over 3 examples that I think speak to many of the ways in which total cost of care can affect your full rate application. To start in the first row, you have a hospital that did not meet the ICC standard, but was better than Medicare benchmark and commercial attainment standards. Specifically, the ICC said this hospital should get a 5% reduction should they decide to file a rate application. But because of their performance in Medicare total cost of care, whereby they are under the benchmark by 38 million, they are entitled to a reward of 20 million. Please note again, this is taking the underage relative to the benchmark and multiplying it by the attributed dollars. And again, that statewide responsibility factor of 54%. After this, the hospital is not eligible for a total cost of care penalty, even though it has grown faster than the statewide average because it has met the attainment standard. That's an important point in the algorithm as well. In terms of commercial total cost of care, this hospital is also entitled to a reward of 54 million, which can be seen in column N. But because the 2 rewards together, 20 million and 54 million, would be greater than how much the hospital is better than its Medicare benchmark, the overall total cost of care reward is capped at 38.5 million. The next example on the second row, which I won't go over in great detail, just shows a hospital that had a fairly good ICC result and that is slightly penalized for being over the Medicare benchmark and is growing faster than the statewide average. One important thing to note here is the ICC cost per case result was not capped by how much the hospital fared relative to its Medicare benchmark. You can see they are above the benchmark, but still would receive funding in a full rate application because of their ICC result. And then lastly, in the third row, we have a hospital that met the ICC standard as well, but it's growing faster than the state in Medicare total cost of care, and it's worse than the commercial benchmark performance. So their ICC answer is all but wiped out due to that fact. They go from having just over a 7% increase, a $4.4 million increase, strictly under an ICC, to a 0.87% increase, or 0.5 million when total cost of care is accounted for. So these next 2 slides I just always include so people can rehash the logic associated with the algorithm. I won't go over in great detail every single one because I kind of touched on all of them when going through the algorithm step by step. But I will note at the end of the final bullet point on these, and that is the idea that we actually will actually cap a hospital's full rate application reward such that it does not allow them to exceed the Medicare benchmark. And I think the reason for this is we do not believe that the full rate application methodology should allow hospitals to excessively exceed their Medicare total cost of care associated with other peer regions in the country that reimburse hospital services through IPPS and OPPS. And the reason for this really is twofold. First, IPPS and OPPS is indeed the alternative that the federal government has for our model. Overnight, they could change our pricing structure and get a lot of cost out. But the notion of the model, and the second point, in my opinion, is we get to maintain higher governmental reimbursement for hospital services in exchange for similar total cost of care outcomes, while at the same time not imperiling the financials of our hospitals, all of which wrapped up together suggests that we actually had care transformation in our model. And then finally, I'll just note that if a hospital does qualify for a rate application, and I've noted this before, but I think it's a very important point, if a hospital does qualify for rate application strictly based on their ICC performance, which is a great indicator of low margins, if not potentially insolvency, their ICC is not capped by its relativity to the Medicare total cost of care benchmark. So in effect, we're not outright capping the full rate application methodology to Medicare benchmark performance. We're only capping the associated rewards from total cost of care performance. This slide just quickly shows you the results currently of the full rate application methodology using the rate year 20 ICC and the calendar year 18 total cost of care benchmark performance. The two columns on the left under the yellow border represents what staff came forward with the original draft recommendation. The two columns on the right was due to an amendment to our policy, our draft policy, whereby we discontinued the historical 2% productivity adjustment in the ICC. And really, the way I think of this slide is if the commissioners told us to rebase all hospitals today based off of the attainment standards we've set forth, this is what would be the net result. But again, harkening back to one of my earlier points, I really don't think the full rate application methodology is going to be utilized unless, of course, a hospital files a full rate application. It's not our intention to initiate a full rate application methodology or a full rate application review. It's more so a lever that the hospitals can utilize should they believe that they cannot be successful in our total cost of care model given their low revenue structure and their relatively efficient care both in the hospital and in their broader region. So the last section I'll go over before talking about the approved recommendations is just how staff envisions the process for full rate applications to work in a total cost of care model. To start, I think it's important to remember that staff does not believe that rate applications should be capped by available funding in the annual set aside or by how much funding we remove from inefficient outliers in the integrated efficiency policy. So in other words, if a hospital is eligible for 50 million and we only have 40 million from the set aside and what we've taken away from inefficient hospitals, the hospital still should get 50 million if they've met the absolute standards in the full rate policy. This notion and the various timelines required under statute and COMAR creates a need for a refined rate application process under my estimation. But before I outline that, I'll just talk about a few of the important deadlines that are associated with our full rate. The two that are the most important in my opinion is as soon as a full rate application is filed or docketed, staff has, the commission has 150 days to adjudicate and make a decision on that. The other important notion associated with that is if we don't actually make a decision with 150 days, which is a lot given, which is a relatively short time period given the complexity of these reviews. If we don't actually do anything within the 150 days, then the full rate application request goes into rates. So there really is a significant impetus for staff to be able to adjudicate these as quickly as possible with approved objective standards that don't make this into a drawn out iterative process. So that's why staff put forward this notion of a refined full rate application process. To start, as we always do with full rate applications, we're going to continue to provide formal recommendations to commissioners in a commission meeting on the merits of the full rate application. And in that, we'll also talk about the impact that actually providing additional revenue would have on our total cost of care performance, which is something we can do rather easily, given the fact that we monitor total cost of care on a monthly basis and report out on that at our commission meetings. Secondly, the commissioners, should they decide to provide additional revenue, will really have one of four options, which are listed at the bottom of the slide. First, they could provide a revenue increase immediately because there are no total cost of care concerns. Secondly, they could provide a revenue increase immediately, but reduce inflation across the board for hospitals due to total cost of care concerns. or on 3 and 4, they could actually delay all or portion of the revenue increase until a semi-annual milestone, at which point the total cost of care impact could be accounted for in the upcoming update factor. So to conclude, I would just say that, commissioners approved our recommendations in the January meeting. I was extremely excited for that because it makes our full rate review a much simpler process. Specifically, though, they approved the use of the ICC and all its supporting methodologies, as well as the total cost of care measures using a geographic attribution. One thing I do want to quickly note here is that while it means those tools will be used over time, it does not lock in time what those tools can actually be. As Brett mentioned earlier, we're looking at the peer groups in the ICC, and that could change the answers of the efficiency policy. And we would want to reflect that in the full rate review. So that would require us potentially modifying these recommendations to account for that. Last thing I'll note is the commissioners did approve the notion that we would have 1 of 4 options to implement a rate enhancement that comports with total cost of care savings tests, but they did not approve the idea that we would have a mutually agreed upon moratorium on rate applications after a rate application was adjudicated. And staff really pursued this because the current regulatory limit in COMAR is only 90 days. And you really can't glean much from a rate application 90 days after one was adjudicated, because these are annual assessments. That said, the commissioners felt pretty strongly they didn't want to be at odds with COMAR in this policy, and instead they advised our council to go back and to look at the 90 days, which they believe is an unrealistic metric, and to revise COMAR to put forward a longer limit, most likely something like 365 days. So I will stop there and see if there's any questions that anyone has.
All right. Any questions for Allan today? You won't be offended if there were none, because there's only one question at the beginning. All right. Well, Allan, thank you so much for participating today. Thank you to all the speakers for volunteering their time. I hope everybody enjoyed today's shorter, condensed presentations. But if you didn't, let me know. I'd love to hear your feedback. Just a couple reminders. Next week, I believe at 3 o'clock will be our Women in Leadership event for the spring. The Women in Leadership events are always some of our best events over the year, and they're not only open to women; they're open to everybody. I've attended a few of them myself, and I always come away with great insight. So please mark that on your calendar, and we look forward to seeing you then. But if I don't talk to you before then, thank you everybody for your participation, and we'll be seeing you soon. Stay safe.